carotid stenting, the procedure. We'll be discussing the procedure, how it is done. We won't be discussing the merits, demerits of carotid stenting versus carotid endarterectomy or its trials. Indications for carotid stenting: a symptomatic patient with more than 70% stenosis in NESET trial, and asymptomatic patients more than 60% stenosis in ACAS trial, and symptomatic patients with stenosis of at least 50 to 69% stenosis. Carotid artery dissection or pseudoaneurysm is also an indication for carotid stenting. The contraindications are complete carotid occlusion, major disabling stroke or on the ipsilateral side or disabling dementia, intracranial tumor, hemorrhage, unstable plaque or thick calcification at site of carotid stenosis, and extreme tortuosity of the vessels. So in a symptomatic patient with TI or minor stroke, Doppler ultrasound should be done, a stenosis more than 50% or a velocity more than 235, and MRA or CT angio to confirm. If it is inconclusive, we go for catheter angiography. If there is a significant stenosis, we'll plan direct treatment. Pre-evaluation of the patient: rule out major stroke within 4 weeks, and anatomical inability to achieve safe vascular access, severe tortuosity of the arch, severe tortuosity, aneurysm, heavy calcification, visible thrombus in a lesion is a strict no-no, total occlusion and long subtotal occlusion, but however that can be done. And clinically, if life expectancy is less than 5 years, contraindications to antiplatelet therapy, and renal dysfunction precluding safe contrast medium administration. Now the modalities: carotid Doppler ultrasound is the first one, and most important, plaque characterization is also very important to plan our treatment. A CT angio or an MR angio should be done prior to it, and this will guide our therapy. The gold standard is digital subtraction angiography, but there is a 1% stroke risk associated with the procedure. Hence, for diagnostic purpose, we would not advise unless CT angio or MR angio is inconclusive, and hence should be done only when an intervention is planned. General evaluation of the patient: ECG, echo, and SOS coronary angiography as coronary disease is involved. Peripheral vascular evaluation for approach and associated peripheral vascular disease. Renal parameters, pre-medications, antiplatelets, usually dual antiplatelets and statins. Antihypertensives should be continued till the morning of the procedure, and on the morning it can be omitted to keep a blood pressure of at least 140/90. Hydration is important, and patient should be adequately hydrated because hypotension and vasovagal many a times occurs in these patients. Now, access. Transfemoral is most commonly used at our institute. Transradial is the new in thing. Direct cervical or transcarotid artery revascularization can be done where a surgical approach is required. Transradial access advantages are its reduction in SS site bleeding, and it is a preferred approach when there is a bovine left internal carotid artery. The catheterization of the left internal carotid artery is easier from the right radial artery in this. However, the sheath size which can be used is 6 or 7 French at the most, and hence proximal protection or larger device, or in case when there is a thrombus formation, that cannot be done. Transfemoral access, now there can be two approaches: 6F sheath or 8F guide, and then these are the steps of the transfemoral approach. We'll go one by one of all the steps. Now, femoral access is done either in ultrasound guidance or a fluoroscopic guidance. This is, so femoral access is done under fluoroscopic guidance, and a vein is also taken. So this is 8 French femoral arterial sheath, and venous sheath. We usually put a temporary pacemaker wire in the IVC in case vasovagal occurs or bradycardia, severe bradycardia occurs, and we attach it on as a standby. Next slide. Then we take a aortic root shoot with 5F pigtail with if dialogue allows a good contrast of 20 cc by 15, and see the arch and arch abnormalities. This is the constant flush system run please. We attach, so during each exchanges of catheter, a constant flush is done, so air embolism is less. Now these are the types of aortic arch. More inferior the origin of the target artery, the more difficult in gaining access to the carotid artery. Aortic root shoot can be avoided if we already know the aortic arch by CT angio or MR angio, so as to decrease the dye load. Now types of catheter. There are Bernstein catheter is the most common catheter used. We usually use the routine Judkins Wright multi-purpose A2 or internal mammary artery to engage the target carotid artery. In difficult cases, a sidewinder catheter can be used. There are sidewinder catheter with different curves can be used, but in most of the cases that is not required. Right? Okay, next. So engaging the carotids, avoid scraping the aortic wall because it can lead to embolize. Use a hydrophilic wire to enter the carotid using a guide, and then you can telescope the guide. This is 8 French guide on 6 French RCA catheter. Next. This is another method where you can under guidance you can enter the external carotid artery. For this, the internal carotid common carotid artery has to be plaque free. Put your catheter in the external carotid artery and put a extra stiff Amplatz wire, and on this your sheath can be advanced to the target common carotid artery. Once your catheter or guide is in place, do a carotid root shoot, a carotid shoot, carotid angio. Usually it is done in ipsilateral LAO view or lateral view. And intracranial angiogram is prior to the procedure is achieved in Townes view, epicranial view. Then comes the protection device. Next. Yeah. So proximal protection versus distal protection. Proximal protection is 9 French and involves having a good external carotid artery, a good opposite side vessel with a normal circle of Willis collateralization. Here the external carotid is blocked with a balloon. The common carotid is a blocked with balloon, hence the flow is retrograde from the opposite carotid through circle of Willis, and then the procedure is carried out. We have not done many cases with proximal protection device. Usually we use the distal protection device, which are shown here: spider, filter wire, Acunet, Embosil and angioguard. We'll demonstrate 2 of this in the future another cases. Embolic protection devices reduces the occurrence of distal cerebral embolization and potential risk of stroke. Distal occlusion balloon was available, but now it is not used. Okay, so this is the Embosil NAV. Can you focus over here? So this is the video. Okay, this is the embo shield. You can see the video also. Fill all the chambers with saline. Fill this syringe with saline and flush this from here till the air comes, all air comes out from here. Then this is the wire on which the embo shield, this is the embo shield, you can see, right? Pull the wire till it enters the black portion here, and then both these are to be pulled together out. So this embo shield has gone inside this catheter. I will again bring this out so you can see. Now the embo shield is inside the catheter. Now while deploying, you detach this and bring your sheath so your embo shield comes out. This is free on the wire. Okay. Okay, next slide. And now see, the constant flushing is on, so that no air can go in. Push your embo shield through this TUI, which is like pacemaker. It can be peeled off. It is a peel off sheath. Next. Now this is the second protection device which I will be showing. This is the another distal protection device, spider. The advantage of it is you can use your workhorse wire to cross a very tight lesion and then guide this over it like a balloon. So there are three color codings in this. There is a green portion, then a transparent portion in between, then white portion and the blue portion, and it is a long 300 centimeter wire. This is the distal neck which acts as the filter. You put it under water, remove all air and pull the wire from behind to bring it into the transparent part of the green portion of the sheath. So once your spider is in that, there is a small hole over here from which you can put your workhorse wire inside it. So the wire would come from the tip, your workhorse wire. You can put this as a microcatheter. We use a microcatheter. Put the wire through the lesion and then guide the catheter over that to the distal to the lesion. Then you can remove that wire and push your spider to this. We'll see the video of that. This is deployment of the embo shield. And this is how embo shield is deployed. Remove the black portion, pull back the white portion, and your embo shield would be deployed. Then remove the catheter. This is how a spider is deployed. First you cross with your workhorse wire. Then the sheath is tracked on it. Sheath is tracked on it beyond the lesion. Then the whisper wire is removed. This is without the wire. Now you push your spider through this sheath. Here comes the spider with its wire. And now you pull back the sheath. So spider will deploy. Then pre-dilatation. Pre-dilatation is usually done with 3 or 4. Larger the balloon, better the result, because during pre-dilatation chances of emboli are less. The maximum chances of embolization are during post-dilatation. This is pre-dilatation with 315 balloon at 10 atmospheres. Then comes the stent. There is closed cell stents and open cell stents, and tapered and non-tapered stents. We are usually using tapered stent because, and you have to size it according to the common carotid artery diameter. Our normal is 6 by 8 into 30 or 40. Open cell is more flexible, more conforming, while closed cell is stiffer. However, the scaffold and support is better with closed cell, and keeps thrombogenic material away from the lumen. However, no trials shows advantage of one over the other, and you can use whichever you are comfortable with. Now comes the stent preparation. This is 8 by 6 into 40. Run the video, please. This is a self-expanding stent. Flush the back portion of it. Remove the stellate and guide it over your wire of the DPD. Unlock it and gently pull back. See, because there can be a lot of jumping in this, and then remove this post deployment. This is how the stent is deployed, right? Now post dilatation. This is the time, run please. This is the time when most vasovagal will occur, and if patient has low blood pressure or heart rate is low, you can upfront give atropine 1 ampule. The post dilatation, you don't have to size it to 100%, even 20% residual is acceptable in this, and usually we size with a 515 or 615 balloon. Post dilate with 560 or 615 balloon. This is post dilatation, and do not go more than 10 atmosphere. Keep your anesthetist ready, because this is the time when most vasovagal and most strokes embolization occurs. Now DPD retrieval. This is of EmboShield. There is a black catheter which is separate from the catheter. Put it over the wire. Constant flush on during each transfers, and then remove. Take the basket into it. This is the retrieval of spider. Now we entered with green one. Now you go with from the other side with the blue one, which is the retriever of this catheter spider, and retrieve similarly the spider. If there is resistance at the level of stent, then do not push very hard, it can distort the stent. Gently come back, balloon again, and then go with it. Take a shoot before removing the spider or distal protection device, so as if embolization has occurred and it is in this, you can do suction prior to removing your DPD. And then comes final check shoots in LAO and lateral view and a Townes view to see the intracranial circulation.